Today we're going to discuss 360 assessment, otherwise called multi-source assessment, and the title I've used 4 questions: why, what, who, and how. And the reasons for these questions are as follows. Why? So why should we go to a single source or 2 sources of assessment to multiple sources of assessment? And who does this assessment? And what are the domains that need to be assessed? And how do we perform this assessment? It's very useful for people as they sit through a workshop like this to reflect on the many instances where their students, residents, or themselves have been assessed by staff such as nursing staff, case managers, practice staff, and so on. That's the non-physician staff. And in a workshop, we can always work through a scenario where we discuss such a case and discuss the challenges as well as strategies that will enhance multi-source assessment. Before talking about any topic in assessment, it's worth discussing Miller's Pyramid of Competence. This is a model which consists of 4 levels of assessment. The bottom 2 levels refer to knows and knows how, and this pertains to assessment of knowledge and applied knowledge. The next level is shows how, which is classically assessed using simulations to have the trainees show how they can perform certain skills. But the real world level is the highest level, or the does level, and this is where multi-source assessment fits in. And before moving further, it is also worth talking about the definition of competence. So competence has been defined as a habitual and judicious use of communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflection in daily practice for the benefit of the individual and the community being served. So this obviously refers to patients as well as society. But competence is not simple. It is multifaceted and includes so many domains that cannot be assessed by a single person and in a single setting. It also pertains to domains such as professionalism, health advocacy, practice-based learning ability, scholarly approach, teamwork ability, and interpersonal skills, and such domains are very difficult to capture by traditional methods. Think about just doing a multiple choice question-based test for this. It's just not possible. Think about assessing this at a single setting. Not possible. Think about these domains being assessed by one assessor. Again, it's not going to give the whole picture. So let's move on to the questions that we started with. So the why question. So why should we do multi-source assessment or 360 assessment? What does it actually add to existing methods of assessment? I think we should remember that medical professionals are not only accountable to themselves to develop knowledge and skills, but then there is a whole host of attitudes they need to develop. They are responsible to society. They are accountable to their patients. And assessment is one way to ensure fitness to practice. As we know, regulatory bodies are always attempting to identify robust methods to assess professional competence and also support evidence of ongoing performance. And that is all of us as professionals undergoing continuing professional development. The second issue to discuss is, does it promote behavior change? After all, the intent of any assessment is to guide behavior change, not just to show that someone has acquired the knowledge or the skills. So moving on to the what question, assessment can be formative or summative. For the most part, a 360 assessment has been formative, meaning assessment for learning, not of learning. there are many countries that use high stakes 360 assessment. Unfortunately, they found several challenges in using this as a robust summative form of assessment. One, there's a lot of preparation that's required by the assessment designers and leaders of education. And the second, a lot of training is needed for assessors or raters, as sometimes faculty are called. But also to remember, there's a heavy burden on an educational office and the entire medical student training program or residency or fellowship training program, which sometimes is just not worth the cost and energy that goes into it. Many studies have actually shown that the best purpose of 360 assessment is to formatively aid the growth of our trainees and remain as an assessment for learning rather than of learning. So next question is, what domains need to be assessed through a 360 assessment? For example, if it's patients who are going to assess trainees, it doesn't make a lot of sense for them to assess application of knowledge or synthesis of knowledge, but it makes a lot of sense for patients to assess interpersonal skills. Similarly, it makes a lot of sense for non-physician staff to assess teamwork skills. How the trainees consider patient safety and quality of care. And then tests are quite sufficient to assess knowledge, and we don't have to be assessing knowledge, even applied knowledge, in our everyday real life situations. So the next question is, who should be doing the assessment? And you can say that if one person assesses trainees, it only provides a snapshot of the trainee's competence. So if you really want to fill the entire puzzle, then it needs to be the faculty, their peers, themselves, patients, other staff. And it also needs to be multiple assessments across the year in order for this assessment to be reliable. And it has been said that a minimum of 6 and a maximum of 20 assessments for very brief assessments, providing snapshots of multiple contexts are needed to enhance reliability. So the next, as far as the assessors themselves are concerned, they need to be trained. Even peers need to be trained. Even patients need to be instructed on what exactly they are assessing the trainees on. And faculty, of course, they need training to first understand the language of assessment, what domains they are assessing, and what are the dimensions of assessment. Other area that we don't talk about often is assessments can be on paper, they can be in numerical form or text form. However, the actual impact on the trainees does not occur until a mentor or an advisor or a coach sits down with all these assessments and does facilitated reflection by the trainees. Lastly, what settings should these be occurring in? Real work settings or simulated educational settings? And what are the tools that need to be employed? How long should they be? What is the language of the assessment? Should it be ratings or should it be narrative comments? So all these are considerations that assessors need to take into account. So a piece of information that a lot of multi-source assessment experts have talked about is, if we are assessing the trainees for growth, for learning, then credibility is a term that needs to be considered as well. If trainees see the assessment information or data as not credible, they reject it. If they reject it, they don't incorporate it. If they don't incorporate it, then it doesn't lead to any sort of growth. And so it's worthwhile looking at what influences or what raises the credibility of assessment data. Where is the feedback or the assessment data coming from? The source. Patients' feedback are among the highest rated feedback amongst our trainees. and it really changes their performance. Faculty feedback has always been highly valued. However, who the faculty are, whether they've worked closely with them, the manner of the faculty interactions with the trainees, they all play a part in credibility. Next is the context. So familiarity with performance, so second-hand and third-hand information is not valued by trainees at all and is rejected pretty quickly. Assessment data based on observation is the most highly valued as far as the context from where assessment is coming from in real life. Next up, content. Surprising as it seems, narrative information is considered more valuable by students, residents, and fellows because they see within specific narrative information a venue for change, a venue for performance growth, whereas numbers don't tell them the whole story. And as much as people like hearing positive ratings alone did not trigger change in performance. So constructive comments are very valuable in driving change. However, the constructive comments have to be given in a certain tone, a positive tone, in a tone that denotes caring on the part of the assessors and coaching strategies, and also specifically targeting behaviors. And finally, the response of trainees to the data. So there needs to be an opportunity for reflection, and we've talked about this before. Facilitated reflection is considered highly valuable in response to assessment data, and also addressing the emotional content. If it's constructive data without any attention to self-esteem, autonomy, or even a game plan for growth, it is rejected very quickly. Also, negative emotion is triggered by data that self-assessment conflicts with. So there are many factors that assessors need to be concerned about in terms of whether their assessment data is credible or not. So in summary, accurate assessment of different domains is essential in order to guide trainee growth in the clinical world, and this can be accomplished by 360 assessment. 360 assessment incorporates the patient voice. After all, patient care, the quality of patient care is the ultimate impact that we're looking at. Assessment data from multiple sources provides a much more complete picture of competence. The construct should be aligned, so which assessor is assessing what domain, so that those constructs should be aligned. The psychometric properties of any assessment include validity. Is this tool assessing what is intended to assess? Reliability. Is this assessment enhancing reproducibility of data? Feasibility. A high burden, a high cost is not going to have the most valid or most reliable assessment tool carry on in the assessment scheme. Training of raters is key, and this includes all manner of assessors. And finally, 360 assessment should be formative, and it helps greatly in coaching for performance improvement, which is the ultimate goal. Thank you.